Our next company and speaker does not need any introductions. Anybody who has dealt with proton therapy knows about ion beam applications, IBA. And our speaker is a very rare combination of a scientific intellect and a leadership acumen. He has a master's in engineering and as a vice president of the IBA commercial applications, he's got a mandate to build and manage relationships with radiation oncology community in the region. Dr. Mou Chergou.
Ladies and gentlemen, we all know that we are running late of time. The good news is that we are still having lunch, but the less good news is that we will have lunch after this session. So please have patience and hopefully we will have lunch after this whole session. Thank you very much.
Well, it could be a good practice for Ramadan in 2 weeks, right? To hold a little bit. So my name is Mou Chergou, and I have the pleasure and honor to present to you today the case for proton therapy. Is it a luxury or clinical necessity? I started personally my career in radiation oncology 21 years ago. If you remember Impact Medical Systems in Las Vegas, one of the first software companies. And then I got really bored in the US, so I wanted to come to the Middle East. And over 6 years, which was perfect timing around 2010, 2011, and all the turmoil happening in the region, I could count many of you as my friends and partners bringing new technology to the Middle East. So we did together the first, for example, first SRS cases in King Hussein Cancer Center in Amman. We did the first FFF treatments in Saudi Arabia in Jeddah, and so on and so forth. And I graduated after that, or 10 years ago, to proton therapy. Many experiences, many successes bringing proton therapy from places to Spain to Kazakhstan, or from Norway to Egypt and so on, but no more dear to me is that dream to bring proton therapy to the Middle East. So the job that I have today in the next 15 or 20 minutes, I'm not quite clear, but is to answer 2 questions. Why proton therapy? Is it a luxury or a clinical necessity? And why IBA actually? Why is it the correct partner for that endeavor? So let's start our journey together. I'll just quickly introduce myself. So naturally I have to introduce ion beam applications, IBA. We're a Belgian company, but with worldwide footprint. You will know us, most probably, all the physicists in the room know us as the leader in proton therapy, leader in radiopharmaceutical accelerators, industrial accelerators, and then you will know us as the leader of proton therapy. We innovate in every field that we go to, and that's also proof. The proof of that is that we have, as of today, 87 dots on this map. Those represent 87 systems sold, 87 proton therapy implementations. These are real numbers because we're a public company. So the dots are either public systems or private ones that are fully funded. We will come back to this slide, I promise. So I'll tell you a little bit more about the dots, but let's start with the basics of physics, ABC. Everybody knows this. The difference between proton therapy and photon therapy is in the entry dose and the exit dose. So where photons will enter with some level of entry dose, then hit the tumor eventually, but then hit critical organs, as Dr. Noor mentioned earlier in the example of left breast. For protons, we have very minimal entry dose, and after that, pretty much or virtually no exit dose. And that's the physics of it. This is what it looks like for patients. So this is a CNS case. So craniospinal, you'll see that for patients with conventional radiation, well, they will receive the dose that they need in the tumor bed and the spine, but they will also receive dose or 70% of it, up to 70% of it, in other organs at risk, where with proton therapy, that's not happening. So we're saving that patient a lot of secondary tumors, a lot of issues down the road. So this is a quick overview of why proton therapy? We improve the local control through dose escalation, reduce side effects, lower the risk of secondary cancers, and it's the treatment of choice for radiation. I will quickly go over each one of these, just so that we will have an idea backed by studies and papers published. Improving local control through dose escalation. Now, all of you are aware of the PIOS trial a few years ago that was trying to explain that with MR-guided treatments or adaptive treatments, you could put up to 60 or escalate the dose to 70 grays, but eventually in the head and neck area, but eventually you hit your limits. With proton therapy, you can actually escalate even further to 80 grays. And that's, yesterday, Professor Armstrong explained that there is no cell that cannot live or that cannot be destroyed with enough grays. That's the point here, dose escalation. The second point of radiotherapy is reduce the side effects. So how do we do that? Professor Armstrong again stole my thunder by explaining that MD Anderson, Stephen Frank, and a consortium published a paper last year at ASCO, and then it was published in the Lancet around November, December this year, where we compare IMRT and IMPT, so photons versus protons in the head and neck region, the nasopharynx. And we could see clearly that for these patients, the reduction of side effect, and then I will come back again to this in a couple of minutes. Lowering risk of secondary cancer, this is really hard for us to prove because an RCT is likely not feasible, but at least we are able to quantify that for virtually all cancers, the risk of secondary cancer is reduced with protons versus photons. And finally, whether it be in the treatment of choice for radiation, this is a slide about rectal malignancies from a courtesy of Dr. Simone in New York, where you could see clearly that for many cases where a photon re-irradiation is impossible, proton can save that patient and give them hope. So I compare when I entered proton therapy 10 years ago to today. There is a large body of evidence, a lot of RCTs that we are being published or have been published recently that proved the benefit of protons versus photons. We talked about at ASTRO last year, Miami Baptist explained that for glioblastoma patients, there was an overall survival benefit, but there is no more important study than the one for nasopharyngeal cancer, the famous MD Anderson study. It explains clearly that for cohort of 440 patients divided over multiple centers, so not only in MD Anderson, but in other centers as well, there is a delta between survival after 5 years of 10%. Professor Armstrong said it yesterday, we took Stephen Frank to different stops all over Europe, in Istanbul, in Rome, in Brussels, and we had together a nice, and with ASTRO, in collaboration with ASTRO, a very nice presentation where he said, if 10% overall survival saving was given by a drug, by the next day, that would be the treatment of choice. That would be the treatment you have to prescribe. Unfortunately, in proton therapy and in radiation oncology in general, we don't have that luxury. But my point here being that we have enough evidence, and it's backed by associations all over the world. For the ASTRO recommendations, they published 2017 and updated in 2023. For ASTRO, basically the indications are divided over three categories. The first one where you really have to treat with proton therapy, and this is the one that I put here in the screen. So generally the ones that you know, chordomas, pediatrics, ocular treatments, some head and neck, some thoracic, and then some abdominal. But we don't have to actually limit ourselves here because there's also a category two where they mentioned that it could be proton therapy could be beneficial, like prostate and others, but we just don't have yet the evidence. That evidence is being created through other discussions and other papers being published. The Dutch model is, and I'll take a second here to explain what it is. So in the US, ASTRO says you have to treat these indications, A, B, C. In Holland, we don't do that. What the Dutch model is basically for every patient that could be eligible for protons, you create a proton plan and a proton plan, and you do an NTCP model calculation, and then you say, okay, this is what I expect the clinical benefit to be. And based on that, if there is enough delta, well, that patient qualifies for protons and they can go to a proton therapy center. If not, they should still be treated on a LINAC. And that's a very pragmatic model. Where does that help is that in the cases like we talked earlier about left breast, or where a young patient could get 5-10 grays to the heart, where that patient would not get proton therapy in Germany or in the US, that patient would qualify for proton therapy in Holland and Denmark. By now, you've been convinced that proton therapy is not a luxury. So you may ask me, well, if that's the case, why are there not enough or not so many proton therapy centers in the world? There are. This is a graph this is an illustration of the top 25 proton cancer centers in the US. 52% of them have protons. 28% are pursuing protons, so they're implementing them right now. So we talk about the MD Andersons, the Miami Baptist, the UPenns, and so on, MSK. All of them have access to a proton therapy program. So about 80%, let's say, have been convinced and have either implemented it, expanding it, or are implementing it now. Closer to us, I chose the Spain example, not because Olivier mentioned it earlier, but because the demographics are very close to the demographics of the GCC. We have about 49 million inhabitants. That's 49 million potential patients, hopefully not. But what that means is that for the Ministry of Health in Spain, they have looked into the evidence right now, and they've said in 2022, we already have 2 proton centers that are existing, both in Madrid, but we are going to implement another 11. So 13 proton centers that will be divided all over Spain, as you can see, and in the Canary Islands. And all of them basically are from IBA. So we have that experience of creating national programs. Further evidence that proton therapy is growing. So this is a map of all of the dots in Europe. Either they are blue, so that means they are already treating patients, or they are in current installation phase. In order to have a successful proton therapy program, we believe that you need a machine that can actually deliver on that promise. A machine that can treat enough patients, but be versatile enough that you can treat all kinds of patients with it. This illustration here where you can see that these are 3 different or 4 different centers, and then the NAPT average in the US. And whether you're center number 1, you're concentrating on head and neck and CNS, or you're center number 4, where you're concentrating more on prostate. Probably this is from Florida by how I look at it. You need a machine that can treat all that, any kind of mixed case. And you also need a machine that can ramp up the numbers. So earlier, one of our, Professor Brock Mackey mentioned that the ambition would be to take it to 50 patients a day. Actually, we can prove that we've done 61 patients a day at UFPTI in Jacksonville, Florida. So we are able to ramp up those numbers because of the versatility of the machine, but also because of a workflow that I will show you. So for that, once you have defined that I need a proton therapy system, what's the correct machine? So what's the ideal PT machine? I don't have a lot of time to go into the technical details, so I will concentrate on a couple points here. The input or the output, which comes from the synchrocyclotron, and then the gantry, which we believe is still an important part of any system that you may need. Currently, we are in a generation or in a technique that we call Penson beam scanning. And what does that mean is basically we take a tumor and we divide it into layers. That's what you see here. And each layer represents a level of energy. And then within each layer, we divide it into spots. And those spots can be about 4 or 6 millimeters. And the smaller the spots, the better precision you are delivering for that patient. So that's what you can see here. That's very important also for lateral dose accuracy. You need a paintbrush that's as accurate as possible. And that can actually make a difference for patients, whether that patient can be treated with protons or not. Going back to this, you'll see that the difference between IBA spot sizes, which are about 6 to 4 millimeters, and the rest of the industry are pretty stark. You also need a machine. I mean, we have heard that idea of having a synchrocyclotron or cyclotron in the same room as the patient. We don't think that's necessarily a great idea because of the neutron dose. But the last technical slide I would show you is that gantry. All of you will say, okay, currently I treat patients, or 7 million patients a year are being treated with radiation therapy all over the world in one situation. They are treated in supine. All of your diagnostics are supine, basically. All of your workflows are supine. We have worked over 10 or 15 years to create a machine that actually mimics exactly the behavior of a LINAC. You treat your patients in supine position, and you have full 360-degree access to that patient. So you can treat from any angle virtually. And that's a compromise that we don't think we have to make. You can do it with the Proteus One. You also have currently on your LINACs the ability to treat your patients in image your patients in isocentric position, whether you want to take a KV comparison or whether you want to take cone beam CT, so that you can see what you're treating actually. So for us, isocentric imaging is very important, and this is a unique position as well in proton therapy. And then finally, like I said, pencil beam scanning, that's a very important distinction with IBA. So you will hear in the market that that's first or second generation, and then after that, there's third and fourth or fifth generation. I'm not sure what they're calling it marketing-wise these days. So, which is called upright or seated treatments. That's not a new idea. It started in the 1950s. Some of the labs in the US had already started treating that way. And we don't necessarily think that that's a correct compromise. I heard earlier, for example, that kids don't necessarily need anesthesia. And I don't think any of the radiation oncologists that I know take any pleasure in giving anesthesia to a patient. It's not actually because of the gantry or the seated position. It's actually because of the fixation of that patient. I have 2 boys, 7 and 5. No matter what you put in front of them, they will move. And that's why, if you remember that slide earlier about the recommendations of AMSTRO and the potential for upright, there's definitely a mismatch. We don't think that necessarily helps proton therapy expansion. We have we had the honor of treating 140,000 patients all over the world. We believe that for the upright treatments, still at 0 patients up to today, maybe we need to think a little bit further about the consequences for patients and have a little bit more look at the data. Or maybe not. If you don't want to take that word from me, you can ask hospitals that have been treating with protons or carbon ions or other particles worldwide. MD Anderson, Penn, Heidelberg, that's been treating for over 15 years. When you ask them, why do you choose a certain way of doing protons, they tell us not all proton beams are equal. So you need a quality beam and a clean beam. Beam design directly impacts clinical precision. That means that I need to treat the way I know or the way that I'm used to. And then a gantry gives us a broader treatment potential, so I can treat patients from all angles possible. That expands patient access. That's a better patient throughput. And that in turn means that maybe the capital cost is higher than a LINAC, but at the end of the day, the cost per patient is clearly better. Now, on to my last slides, because we're not necessarily stopping here. This is a picture from Trento, one of our innovative centers in Italy. They started treating with arc therapy with protons last year. They've already treated about 50 head and neck patients. And where they tell us the difference is that now I'm opening the door for some patients where I couldn't do them before, but I also can treat 30% up more patients. And that's a significant way to bring the cost per patient down. But the next step that we're still working on with a bunch of academic centers and industry partners is flash therapy. There is a conformal flash alliance that is led by IBA that's already treated or finished a canine study at UPenn in Philadelphia. And they are about to receive an IDE to start a human-based flash therapy study, especially on head and neck this year. So these are technological innovations that are taking place, but we're not stopping there. We talked earlier about the panel talked about the need for training and sharing knowledge. PTCOG, which is the Proton Particle Therapy Association plus IBA, started what we call PT Academy. And basically what that is a global hub for particle therapy training and education, where you can go and ask questions to these experts plus Heidelberg and say, okay, for example, I have a carcinoma case, how can I treat it with protons? How can I learn? And you have videos and access to knowledge base, knowledge database, and access to a network that will help you figure out how to do that. So we believe that that's key to keep bringing more protons into the region, and that's how we are going to put more dots here. The quantity of dots is great, but also the quality. MD Anderson, Heidelberg, Penn just last year, and other ones. But like I said, I am no more proud than, I'm the most proud that I finally could bring proton therapy to Dubai. DHA had granted an initial approval to Yes Healthcare about a year ago, and we started working with them. We don't call them our customers, they are our partners. We worked with them over 2 or 3 years to bring proton therapy to reality, and we hope that we can, we plan to deliver what Olivier said earlier, is that we can treat a patient by 2028. So take home messages real quick as I hit my 20 minutes limit. Proton therapy is effective, so we have demonstrated that question. Is it a luxury or is it a clinical necessity? It is a necessity. It is effective. It has demonstrated clinical benefits. And why IBA? Well, we are the leader of that field. There is only one leader, and that's measured by the number of centers and by the quality of our partners. If you want to find out more about that, you're all invited to our users meeting in Belgium in April. So way after Eid, when Ramadan is over, all of you are invited. Please join us. There you get to know all of those 87 centers plus, and you get to talk to all of the key names in proton therapy, the Stephen Franks, the Jim Metzes, and so on. And this is a unique opportunity that nobody else can provide you. We can network with them. You can learn from them in small sessions or one-on-one and in dinner. And maybe you can come say hi to us as well. Thank you.